Good afternoon, ladies and gentlemen. We're going to go ahead and get started. We're going to try and stay on time, and I'm going to ask the presenters. There's a timer right down there. Please stay on time. We want to make sure that we have time afterwards to ask some questions. And so as you present, the presenters come on up and have a seat after you've presented. It's you're planning your next complex hernia repair. We got some real experts that are going to teach us individual segments of doing this, and then we'll look forward to the conversations afterwards. The first presenter is going to be Eric Pauline. So Eric is one of the surgeons who actually has transformed a lot of what we do in peristomal hernias, and now making radiology cool. And indeed, one of the most important things we can do is show up prepared, and this is such a huge part of what we do in getting ready for surgery. So Eric, thank you.
That's my conclusion. And any questions? No, honestly, a very good capsule summary, and thanks for the privilege of the podium. We're going to talk about preoperative imaging predictive models, and I do have some disclosures, but we're not going to talk about any products today. So I think, as Dr. Henneford just said, every good hernia repair begins with a plan, and this is a great Abraham Lincoln quote: "Give me 6 hours to chop down a tree, and I'm going to spend the first 4 sharpening the axe." And honestly, I mean, you all know this experientially. This is, preparing patients for the operation. It's looking at the images. It's getting the old op notes and being ready to go, because if you don't know where you're going, you're going to end up someplace else. And the last thing that I'm not a surgeon who likes surprises. It's why I'm not a trauma surgeon. I like to be prepared. I like to know what I'm going to do, and then I like to go do it, and then I like to go home. So we're going to talk about imaging for predictive purposes in the management of hernias, and that's really my only objective. How do we use imaging? I mean, I use it a lot of different ways when I'm managing a patient. I talk a lot about the first 3 of these, but today we're going to take a little side branch here and see if we can sort of ask the question, when you're looking at preoperative imaging, can it tell us what surgery we should do? Can it tell us who might need an operation? What can we predict based off of imaging? I'm going to point out, before I talk about predictive models, that CT interpretation is really quite terrible. This is a group of radiologists who looked back at 7 years of their X-ray reports for the word addenda, and they found 709 addenda representing 785 diagnostic errors, 0.5% of all reports. 84% represented a new finding, and 5% would be an upgrade in the severity. Vascular findings were the most common thing, but 8.3%, the second most common finding, was a ventral hernia that was on the scan and either not reported or incorrectly reported. Of those, they changed the addenda quite regularly and changed the report. 30.6% related to a comparison of prior images. 20% were just getting new information, like someone called and said, hey, that patient had a surgery, and that's a hernia, not a diastasis. And then oftentimes there were requests for re-reviews. And despite the fact that it's 2024 and we're going to talk about, can imaging help predict and can AI help in our next session, I think honestly the best way to be able to predict what's going to happen during the surgery is to just be methodical about it. And this is a great system to kind of think about when you're looking at a scan. You want to think about and look at all of these things, and I think that if you can put this together in your own mind, probably right now the best way to be good at planning the surgery is just experience and you doing this regularly. All right, but with that said, let's talk about whether CT scan can predict emergency operations. So this is a retrospective study of patients who underwent emergency surgery for bowel-related complications over a 6-year period. And they case matched those patients who needed an emergency operation with people who didn't get surgery in a 1-to-3 fashion. And they evaluated characteristics of the patient's hernia and patient characteristics themselves and asked what is associated with emergency surgery. So things. There was really no difference between whether the hernias were primary or incisional. The hernias did have a difference in area, though, with the people needing an acute surgery having larger hernias in terms of the area. And what these folks came up with is this thing called an OER score, the odds ratio of emergency repair score. You get some points for your BMI being high. You get 7 points for ascites. And I want to point out, this is not like a little bit of fluid in the hernia sac because it's incarcerated. This is legitimate, I have liver failure and ascites, okay? And so you obviously get a fair number of points for that. And then you get some points based off of the CT scan. So you got to measure the angle that the sac comes off the abdominal wall. That can be acute, it can be more obtuse, and then you want to measure the sac height. And when you put these things together, if you've got a score that's greater than 10, you've got a 2.5 odds ratio of needing an emergency repair. And so if you meet somebody in clinic with these characteristics, you might want to think about, hey, should this person be getting a surgery even though they may not be ready or is not as optimized as I like them to be because of that? So how would I use this data? I would use it cautiously. I think primarily because a lot of these folks are already having surgery considered. And for example, if you meet an obese patient with underlying cirrhosis, they automatically have a high score. It has nothing to do with the hernia at all. Their points are already there just based off of those two factors. And obviously, in a liver failure patient, you'd be more concerned about decompensation after the liver than necessarily the risk of the hernia. You got to balance those risks. I also want to point out that these are people who had bowel issues related to their hernia, not pain issues, not quality of life issues. So we're really assessing a very limited amount of information with this study. What about just a simple umbilical hernia? Obviously they come in a variety of shapes and sizes. This is a retrospective analysis of people who, again, underwent elective versus emergency umbilical hernia surgery in Switzerland. The reason for repair wasn't really considered, but hernia characteristics were evaluated, including operative reports. And then importantly, they looked at all types of imaging ahead of time. If the patient had imaging and they could get some numbers, they did it. And what they were looking at was this hernia neck to hernia sac ratio. You measure the widest part of the neck and the widest part of the sac, and you do a little bit of math, and we figure out the numbers. And this is kind of what those look like on a CT scan or on an MRI. You can sort of do it. And obviously, the complicated hernia already looks complicated, right? It's got much more content in it. It's got a lot of edema in the omental fat there. There are other characteristics here that might tip you off that there's going to be a problem, but you can see the ratios are calculated there. Now, when they looked at these, the hernia sizes and the hernia neck sizes were not statistically different. It was really the hernia size itself that was different. And obviously, if you have a bigger sac through a smaller neck, those are people who we think are perhaps more likely to have a complication. But again, a significant portion of the people in this study who needed an emergency operation, 30%, had underlying cirrhosis. So again, we're seeing that people with underlying hepatic issues are more likely to present and need emergency surgery, whether that's a big hernia repair like in the last study or in a simple umbilical that may just have some fat in it. The authors concluded, though, that anybody with the ratio greater than 2.5 should be repaired regardless of symptoms. So if you meet somebody in your clinic and they have that ratio, they're suggesting that you fix it because of a 53% increased risk of complications. It appears to be very sensitive and specific with a high positive and negative predictive value. But again, a lot of these folks had underlying hepatic cirrhosis. Can you use this same score for a ventral hernia? Well, the answer is you can. These folks presented this at SAGES 2 years ago, and it's now published. They looked at 166 patients. Half got emergency surgery and half didn't. In the emergency group, they were more likely to be male, and they were more likely to be umbilical hernias, and they were more likely to be recurrent hernias. And when they compared the hernia neck to sac ratio, they again got a number of around 2.5, right? They got 2.4 versus 1.7. So, it may be that in the world of ventral hernias, there's this magic ratio of around 2.5 comparing the neck to the sac ratio that suggests that someone is more likely to have an acute problem after as a result of their hernia and need an emergency operation. Let's talk about maybe a little bit about what operation to do. I think many of us are familiar with the concept of the Carbonell ratio. I've heard it mentioned multiple times here, and this is a very simple predictive model that you can do where you simply measure the size of the retromuscular space and you measure the size of the ventral hernia. And if the sum of the retrorectus width is greater than twice the hernia width, then you can probably do the operation as just a retrorectus operation without the need for a posterior or additional anterior component separation. And from that paper, I think are a really good example. In A, you see somebody who's got a 4-centimeter wide rectus bilaterally, a 9-centimeter defect. That's a ratio of just about 1. That is somebody who is likely going to need an additional maneuver, either to place mesh or to release tension. But look at this much larger hernia. It's got a much higher neck to sac ratio. It certainly looks more impressive. But if you actually measure the distance of the rectus space in the hernia itself, that's a patient who they repaired with just a retrorectus operation. No TAR, no anterior component separation. How is this helpful? I think it helps flavor the discussion a bit with patients when you see them in clinic. And certainly if you're planning operative time and I'm likely going to need to do some additional component release, you're going to probably add a couple extra minutes onto that OR schedule for yourself versus somebody that's just a straightforward retrorectus operation. What about the need for bowel work? These are some folks from Japan who actually looked at patients who presented with incarcerated hernias of the myopectoneal orifice, so inguinals, femorals, over a 9-year period. Most of them were inguinal. There were a few femorals and obturators in there as well. They excluded patients who did not get IV contrast because obviously if you're looking at is the bowel dead, you need contrast to figure that out. And they were looking mostly at small bowel, not colon, so they threw a number of patients out. And they based the study off the fact that the radiology literature suggests that you can actually predict the likelihood of ischemia by utilizing IV contrast changes in the wall of the bowel. So how does that look if you compare left and right, the pre-contrast versus the post-contrast? On the right-hand side there, that bowel uniformly enhances. That is very happy bowel, okay? This is some bowel that is partly enhanced. You can see that when they give the contrast, 50% of it lights up, so that's a, meh. You get this one here where there's just the tiniest amount of bowel enhancement. And then you've got these that are completely non-enhanced before and after, and this is highly concerning for dead intestine. What did they find? When there were no apparent defects in the rim enhancement, right, so uniform enhancement of contrast, they had equal numbers of patients in the resection and non-resection group, okay? When there was absent contrast, more likely to need a resection, statistically significant. And so what do you conclude with all of this? Well, they also had some other problems. If you were greater than 80, you were more likely to need a bowel resection. If there was an absence of bowel wall enhancement, complete absence, it was highly significant with a very high odds ratio of needing a bowel resection. But there were some caveats. This was obviously a retrospective evaluation of the imaging, and the decision to resect and to go to the operating room and when were really based off of surgeon judgment. But ultimately, I think the absence of enhancement is strongly associated with ischemia. So if it does not enhance, it's probably dead. And so it's a good rule, and you might say, let's go to the operating room in that patient. But if it does enhance, it's not really sensitive or specific, and so you're still going to have to base that off of your clinical judgment. And so obviously, a lot of those folks who needed a resection, I think, could have been predicted just based off of how they presented. I'm going to briefly delve into radiomics here. I'm not going to talk about it too much, other than to say that this is a field of radiology that utilizes features on the imaging that are not visible to your eye, right? We can measure the distance of something. But what radiomics does is it looks at hidden features. An example in this study here from some colleagues of mine from Penn State, looking at body fat composition, fatty liver infiltration, spleen fat infiltration. If you look at those features, can you use them to help you predict an outcome? And in this particular, these two studies by Anna Sensago, what she looked at was whether patients had fatty liver disease, undiagnosed but on imaging studies, and whether they were likely to have wound complications. And it turns out if you're diabetic and you have a fatty liver on your imaging studies, you are 11 times more likely to develop a surgical site occurrence requiring a procedural intervention. Does that change how you manage the patient? Again, probably not, but if you had access to these numbers and your radiology report simply spit out, oh, by the way, this person has fatty liver, so if you're doing a hernia, you might want to let them know that they, maybe they need a drain. Maybe you should definitely leave a drain in that patient. So I think it flavors the discussion that you might have in terms of predicting potential bad outcomes. I'm going to end very briefly here with some work from Dr. Henneford and his group. I don't want to step on the toes of our next speaker talking about artificial intelligence, but Todd looked at whether artificial intelligence, a deep learning matrix, could actually look at imaging studies of patients who had hernia surgery and predict outcome. So they took selected CT scan images from 369 other patients, and they asked the deep learning matrix to tell them whether they felt that that patient and those images were likely to represent somebody who was going to be a surgical complexity, meaning the need for a component separation, whether they were likely to get a surgical site infection or to have respiratory issues after surgery. Essentially, even though no one really knows what the deep learning matrix is looking at, it was able to predict outcomes. So this is the receiver operator curve here for surgical complexity. If you look at the upper part of the curve, there's a larger area under the curve of 83%. That's the computer algorithm saying, I think this person is likely to need a component separation, versus the surgeon prediction underneath, which was only 64. So the algorithm was able to outproduce the surgeons. And again, this is people who have years of experience making these judgments versus a computer doing something that we can't even really articulate. This is amazing stuff because I think it does help you have an understanding of what the future of hernia repair might be. The problem is none of the things that I've showed you are widely available. The earlier ones where you can measure the defect yourself, that's great, but you've got to do it yourself. You've got to take the time to do it. And so I think even the simple implementation of automatic algorithms that say, I am an algorithm that can measure the neck and the sac, that can tell you whether there's bowel wall enhancement, would make this a lot easier. Obviously, this type of work is next generation, and I think we'll hear more of it in our upcoming talk on artificial intelligence. So I'll conclude by saying that imaging studies do have the ability to help guide your decisions, and they can help you think about what surgery to do, when to do it, and whether you might need to resect bowel. But as with all things surgical, a lot of this is still clinical judgment and experience, and obviously patient risk stratification. In particular, as I've mentioned several times, the patient's underlying risk for hepatic failure for patients who have liver disease is important. None of these decisions are based solely on imaging, and I wouldn't want anybody to do that. Looking forward to questions. Thank you for the podium.
Thanks, Eric. Your passion for imaging is maybe only exceeded by your passion for cheese, I suppose. Sorry, I had to say it. I'd like to introduce Dr. Rangan to the podium, joining us from India to speak on risk stratification and AI.
And this is very personal, and like most surgeons, I have my own personal graveyard, which I visit from time to time. This was way back in 2017 when I was a resident in general surgery. And I was operating on a patient who has had a big incisional hernia for the past 15 years. He shared even his part of his first name with me, and I had never heard of component separation, and I was struggling, and my attending and I literally had to mobilize the entire skin subcutaneous fat till the flanks, and we tightly sewed it shut. He never came out of the ventilator. If I go to the next slide. How do I go to the next slide? Yeah, I'm Vinayak Rangan, and I'm a fellow in pediatric surgery, and I also work with some tech bros teaching them how to apply AI in surgery and endoscopy. So this talk, the disclaimer is that this talk is not for the smart people. The smart people know how to read CT scans. This talk is for the people in the back rows who find it difficult to read the CT scan and try to understand what HNR is. So disclosures, I founded Curium Life, which is essentially a consortium of surgeons and deep tech researchers trying to make surgery safer. So why hernias? Hernia is a difficult problem. It is difficult to identify, often difficult to classify, and it is a problem where WID often comes into question. And why is that? Because it's not standardized. Unlike breast cancer or pancreatic cancer, where you are likely to get the same surgery in Pennsylvania or Pyongyang, you might not get the same surgery in the same hospital by two different surgeons. And sometimes even two different surgeons might suggest, same surgeon might suggest two different surgeries. So there's no need to elaborate on the problem statement over here. It remains one of the most widely performed surgeries. And as most patients survive major abdominal surgeries, cancers, transplant, we see that the complexity of procedures and surgeries keeps increasing. Every day, surgeons learn new techniques, and like Professor Ramana said, surgeons devote their lives to misery. Yet, our colleagues in front of the black screens give reports which are rooted in the 1990s. The lack of standardization is apparent, again, unlike breast cancer. And there is, again, a lack of clarity with regards to what type of mesh to put and what kind of procedure to perform. The costs are staggering. It's almost $10 billion every year. But there is one statistic that kind of stands out. And every 1% reduction in recurrence can end up saving the healthcare system $140 million, and that is huge. Surgical decision-making is difficult, and the mainstream media has not been very kind either. But the fact remains that complex hernias are increasing in number, and challenges in choosing the right mesh, the right plane, the right surgery often comes, and often it also comes down to choosing the right surgeon as well. The question is, who should be performing these surgeries? We had a very insightful talk by Professor Nowitzki, who spoke about setting up specialist AWR services or subdivisions. The reality is that how do we ensure that the large hernias, which are shown by Professor Yuri, are referred to the specialist services? The community surgeon is essentially the pillar of the society, and he's the one who is going to see most of the hernia cases. And hernia being one of the most common problems all over the world, how do you ensure that the surgeon has the ability to identify which surgery is complex and which surgery is not so complex, which can be performed in the community setting? And you cannot expect a community surgeon to refer all the hernia cases and he's going to latch onto you. So what we essentially wish to do is create an ecosystem that allows the community system to refer the most complex cases to the specialist and make sure that the patient is overall benefited and is actually able to utilize the services of these specialist hernia units. So CT imaging is the norm. it's infinitely better than clinical examination. There is improved visualization. It helps multi-organ visualization. You can look at the liver, pancreas, even though some hernia surgeons tell me that pancreas is not very useful. So then the radiologists gift us this, an incredible hodgepodge of words that often add no value. And if you don't know how to read those black and white things, it can become quite confusing. You should be as smart as Eric to read those, but yeah, for most of us, it's kind of difficult. There are significant communication gaps. There is lack of access to relevant details that actually matter. And obviously, vocabulary is a major challenge. In fact, papers have been written on how to use vocabulary better. So then, sometimes radiologists try to put some effort and gift us this. There's a lot of information, a lot of measurements, but I simply don't know how to measure this. I genuinely wish I was smart enough to understand this. So what would you do? So what do hernia surgeons need? They need objective measurements and then a subjective analysis of the objective parameters. So 3 major questions come. Is there a mesh? Was an old repair performed? Will the fascia close? And what is the risk of complications? And then there are entirely subjective parameters which talk about adhesions and complexity, which add a little more depth to the hernia surgeon who likes to be a little more prepared. So I think the bulk of research has been performed by the Hannaford team. He's over here. And the research has been pretty remarkable. And I think Eric spoke about this. What was really amazing was the ability to predict the complexity of the repair. And I think that is going to be the future of hernia surgery. So when it comes to the AI algorithms and AI in any form of surgery, the tech bureaus have a major problem. They think the solution to any major problem is throwing a large amount of data into the pool and waiting for miracles to happen. Yes, sometimes miracles do happen, but most times they don't. And that is the reason why we don't see many of these deep learning algorithms in daily practice. They remain the subject of great presentations. They're absolutely great to hear. And they are great topics for discussion over drinks in the evening, during the after party. But now the major question is, how do I bring this to the OR? So what does AI need to do to be actually good? You need a good volume of data. And that's obviously high quality. The data should be heterogeneous. The learning should be supervised and focused. There should be a focus on relevant variables, which means I focus on defect width, volume ratios, rectus width, and then use AI tools to arrive at a diagnosis. The reason why supervised learning works better, where you annotate the parameters on a CT scan, is that you don't waste crazy amounts of time trying to look at variables that don't matter, like the Hounsfield unit density of liver and how the pancreas looks. Unsupervised learning wastes time, it wastes bandwidth, and it wastes computing power, sheer amount of computing power. In a country like India, computing power is actually expensive, and I wouldn't want to waste computing power trying to look at the Hounsfield unit of pancreas. The other reason is obviously because I try to stay away from the pancreas, as all of you should be staying away. Yes, so the solution does not lie in throwing large amounts of data at deep learning algorithms. The problems of data availability can be solved by supervised learning, arriving at solutions in a stepwise fashion. Asking the algorithm to analyze a CT scan without looking at the defect width, rectus width, or the volume ratios is a wasteful exercise. So you try to look at all these parameters, and then you can use AI to measure these parameters, and then use algorithms to arrive at the actual question, does this need component separation? So when I say AI, I always used to imagine that there was one giant algorithm that figures everything at the same time. But I soon realized, after working with much smarter people, that it's not Lord of the Rings. There is no one ring to rule it all. So it requires multiple algorithms that solve multiple problems. So the tile on the left represents the defect. And what you see over here is the prediction by our AI tool. So similar thing with volumetry. We are able to identify the volume of the sac on a CT scan. And the tile on the left is the ground truth, which has been marked by the radiologist or an expert surgeon. And the tile on the right is the prediction by the AI model. So all of these are different models. So we are looking at the abdominal cavity volume. And the abdominal cavity volume, unlike the actual Tanaka index, does not utilize just the formula of the ellipsoid, 4/3 pi r cube. We actually look into the bare areas of the liver, try to reconstruct the abdomen on a 3D model, and try to see how we can figure out the volume of the abdomen. So here, this is where what Eric was talking about, radiomics, comes into question. the algorithm looks into features on a CT scan which the human eye cannot analyze. It's kind of like a canine who is able to hear frequencies which a human cannot. And there you see a mesh over there. You can, you can identify the mesh with a tag. An expert can, zoom into the CT scan, try to look at, find if the mesh is over there. We had an expert hernia surgeon who was able to mark the mesh out for us. The radiologist couldn't. And the prediction was able to match the findings of the expert surgeon. Same thing with diastase recti. So essentially, the advantage of having multiple algorithms is there is no rate limiting step. If one algorithm malfunctions, I can work exclusively on that. Guidelines change. What was sacrosanct yesterday is heresy today. Suppose someone tells me that you should not be doing ETEPs at all. I can just change the weights of the algorithms that recommends ETEP for a particular scenario. So all the different algorithms work like gears in tandem. So what is the pathway? How are we doing this thing? So what we essentially are trying to visualize, or what we are building right now, is you upload a CT scan, and then you enter a little bit of information, not too much, because we know that surgeons hate working on computers and filling data points. And then a standardized report is generated. It talks about the defects, the contents, and for those of you who believe in it, the EHS classification as well. The icing on the cake is obviously an automated report for your volumetric ratios. This is something the radiologists love. Anything that makes life easier for them and allows them to have more coffee, I think they kind of love it. A little bit about the diastasis. These are actual reports. And sarcopenia. We have done a clinical trial in our algorithm for sarcopenia. So it's a separate algorithm for sarcopenia, where the algorithm identifies the vertebral level, identifies the psoas muscle at the L3 level, and is also able to predict the Hounfield density of the psoas muscle. And we've done a clinical trial for 700 patients undergoing liver resection in a major tertiary cancer care hospital. The results are promising. The paper will be out soon, and we predict that sarcopenia is going to play a major role in complex AWR as well. So this is where you add value by predicting what would be the probability of component separation. This is something which is in development, so I don't have actual data. And this is where you actually add significant value, because if a surgeon in rural Pennsylvania wants to refer a patient that's beyond the scope to Eric, this is the part of the report he's going to be looking at. Everything else doesn't matter. The aim is to make sure that the right surgery is performed on the right patient by the right surgeon. So I know this is going to be controversial, but our algorithms can also recommend what surgery you can perform and maybe not perform as well. These are obviously recommendations, not prescriptions, and cover a variety of procedures. Basically, they cover the entire spectrum of training and skills of the various types of operating surgeons. So the ultimate holy grail is what Professor Henniford was trying to do, and we are trying that as well, is to work on the ability to predict complications and ultimately predict how much cost we can save. And for those of you who are worried about computer making decisions, I'm a surgeon, so I can understand the pain as well, is that what we are visualizing is essentially a combination of machine learning algorithms and rules-based engines. The rules-based engines are guardrails that prevent common sense from going off the rails, essentially. So as a team, we believe that if we need to take AI to the operating rooms to stratify risk and aim for better outcomes, supervised learning is the key. It is painful, it takes time, it needs a lot of surgeon input, and I do believe that it is kind of worth it. There is a very small overlap between the ability to read CT scans, perform world-class surgery, and choosing the right patient. Our aim is to make sure that we are able to democratize this. Thank you so much. I hope to see you in Chennai, and we have great beaches and beautiful temples. I hope you can see you in March. Thank you.
Very good. Thank you very much. So next we'll have Bola Aladabami, who's going to come up from Baylor Scott and White, talking about managing old mesh and prior sublay repairs, something most of us have faced in our career. Bola, welcome.
Privileged to be on the stage today. As Dr. Henniford said, I'll be talking about multi-recurrent ventral hernias and managing old mesh and prior sublay repairs. I'm a consultant for AbbVie and Bard Duval. This will not influence this talk in any formal way. The goal today is to simplify how to manage recurrent hernias and also streamline the management of mesh in this patient population. We'll plan to reinforce this with clinical case scenarios, and I'll encourage participation from the panel and also the audience. Before we proceed, let's ensure we're all speaking the same language. A sublet repair is a peritoneal repair or retrorectus repair. A synthetic mesh is a permanent scaffold made out of plastic. A biological bioabsorbable mesh is a temporary scaffold. And in future parts of this presentation, you're going to see a flow diagram where the red line indicates no and the green line indicates yes. We all know that this recurrent hernia is extremely complex. Patients have failed multiple repairs in the past, limiting their options for intervention. They also have an increased risk of recurrence. They come in as old patients with multiple comorbidities, which also need to be optimized prior to surgical intervention. This case is technically challenging and require frequent changes and pivoting in the operating room. So I just said this is a tough case to do. Why do it in the first place? It's all about the quality of life. We're trying to reduce the pain of these patients, improve the economic productivity, and also improve the activities of daily living. The first part of the assessment is actually figuring out the rationale for repairing these patients. Why do they need another hernia repair? A physical examination looking at the size of their defect, the location of their defect, and the compliance with the abdominal wall. And also, as already emphasized in the first two presentations, evaluating the CT scan, both the old and the new, to see what's going on with their hernia. However, the deep dive actually comes in looking at their old operative reports and also their past surgical history. You want to know what type of hernia they've had done before. For example, a laparoscopic hernia repair done in the United States is probably a repair with an intraperitoneal mesh, which gives you a location of the mesh. You want to know the size of the mesh. The size of the mesh tells you how much of the plane has been used previously. And if they've had a TAR done and they have a 15 by 20 centimeter mesh, they potentially they had a limited TAR done without a full dissection of the retroperitoneal space or retromuscular space. You also want to read the op note to see if they've truly had a component separation. I've seen time and time again where they say patient has had an external oblique release done, and once you read the note, they've only had a subcutaneous flap raised. I've actually even called the surgeon before and he confirmed, hey, I didn't do an oblique release, I actually just did a subcu flap. Knowing the complications they had from their previous repair is also important. Why? Because you can get to optimize them prior to surgery and also know how to manage the complications that may arise post-operatively. Now you have to synthesize the data. Why did they recur? Is it because of a technical issue, or is this a true recurrence of just an injury to the abdominal wall? What patient factors played a role in this hernia coming back? And if there are, how can we optimize it? I know this is no longer in fashion anymore, but I'm going to say optimize, optimize, optimize. You win the battle prior to getting to the operating room. And coming up with a preoperative plan prior to getting to the operating room increases your chance of success significantly. The first phase of operating planning applies to 70 to 80% of the patient population. This simply says, if there's a free peritoneal plane or retrorectus plane, use it. The first thing I ask when I see a patient in clinic is, what planes are available? If they have a free peritoneal or retrorectus plane, I use that plane for my repair. If I already have permanent mesh in place, I ask, what layers have mesh in place? And is it permanent mesh? If they have a biological bioabsorbable mesh in one of the planes, then that is my primary target for my next repair. If I already have permanent mesh in both layers, then I want to know the size of the mesh present. For example, a 15 by 20 centimeter mesh in the peritoneal space lets me know I still have a lot of peritoneum to work with. However, a 15 by 20 centimeter mesh in the retrorectus space lets me know I might have to do a release to actually get good and adequate mesh overlap. The next phase applies to complex patients, large defects, or complex hernia history. It simply says, do what you're most comfortable doing. Pray they've not had a previous component separation before. And if they've had, eat your Wheaties and get ready for a redo repair. So first question I always ask is, is the component separation needed? If they don't need a component separation, then life is your oyster. Do what makes you happy. If, however, they need a component separation, the next question is, what type of component separation have they had in the past? The location, the laterality, and the extent. For patients that have had a previous external oblique release done, I tend to do a redo external oblique release in those patient populations. However, Warren et al. Has shown in 2022 that you can also do a TAR in that patient population, but my preference is a redo external oblique release in that patient population. For patients that have had a previous TAR done before, I want to know if it's a unilateral TAR or bilateral TAR or limited TAR. For patients that have had a unilateral TAR done previously, then I plan for a contralateral TAR with a possible redo at the ipsilateral side. For patients that have had a limited TAR, then I know that I could potentially get in that retroperitoneal retromuscular space with a challenging redo TAR, but not as bad as if they've had a full utilization of that retromuscular space. What are your bailouts? You can have the best plans in the world, but sometimes it just doesn't come together. In certain instances, you might have to do an intraperitoneal mesh, sometimes a primary repair and onlay mesh, and occasionally, if the muscles don't come together, a bridge and repair. Now let's go to mesh management. To make it very simple, if the mesh is not infected, and you don't have multiple layers of mesh in place, you don't have to excise it. Leave it in place. If, however, the mesh is infected, I plan to excise the mesh in its entirety. In certain situations where there are legal complications or implications, for example, meshes that are recoiled, or the patient comes and says, hey, my lawyer is suing the company, then I consider excising those meshes. Intraoperatively, when it comes to a mesh repair, the normal instinct we have is to jump in and excise the mesh. Fight that instinct. Because doing that will potentially blow the plane you have and lead to increased tension when you're trying to close that sublay plane. So my first step when I get in is to assess the reason for hernia recurrence. And then I tend to use that mesh to get access into that redo plane. The words of my fellowship director still sticks in my head, bovie right on the mesh to get into the right plane. Once you get access to your right plane, then you can then determine if you need to excise the mesh or not, but try and leave the mesh in place within reason. Now, this is easier to do for peritoneal repair than the retrorectus repair, but it's still technically feasible for retrorectus repair. Do not just tack the old mesh in place and close the fascia. I've read that in op notes before. If the mesh pulls away once, it'll pull away again. If there is no viable plane after your mesh has been excised, then consider a two-stage repair, especially if it's an infected case. Now to our clinical scenarios. The first patient is a 41-year-old female who has had a previous open umbilical hernia repair, location of mesh unknown, or type of mesh used unknown, and then had a repair with a robotic tap repair with a 10 by 10 peritoneal DS mesh. On examination, she has an 8 by 8 centimeter defect, and this is what her CT scan looks like. How you guys fix this patient in your clinic? Yep. Okay. Alley-oop. Okay, so options include, obviously, a robotic tap repair, a robotic ETEP repair, a robotic ETEP with a unilateral TAR, a robotic transabdominal repair, because we're looking at a free retrorectus plane, and we know the peritoneal plane has already been used. In this patient, however, we went with an open peritoneal repair. The previous mesh was noted to be displaced to the left side of the abdominal wall, so the right side of the peritoneum was actually pristine. We started off by getting our peritoneal dissection on the right side of the abdominal wall, and then proceeded to the left side. Excising the mesh immediately would have led to increased peritoneal tension, so we left the mesh in place and closed it and put in a new layer of mesh above that. I know I said previously that we should have gone to the retrorectus plane, but you should not follow algorithms blindly. In this situation, there was no need to violate the retrorectus plane since we had an intact and viable peritoneal plane. The next patient is a 79-year-old male presented to our clinic with an intercutaneous fistula and exposed mesh. He's had 7 previous hernia repairs before. We only had 3 of his previous operative notes available for his hernia repair. Initially had a reported plication of diastasis recti with onlay mesh, and then had an open repair of the incisional hernia with ventral ax mesh. We don't know the size and location of the mesh. He then had an open repair of his hernia with an intraperitoneal mesh, which was tacked 15 times, and they retacked the old mesh 15 times, and then placed the previous onlay mesh over the bridging repair he did. And then subsequently had another open repair of his hernia with intraperitoneal ventral X mesh. This is what this picture looked like. He had exposed mesh with a 7 by 8 centimeter defect. A CT scan showed a 12 centimeter defect in the rectus muscle. The contrast confirmed the presence of the EC fistula and also showed intraperitoneal mesh available or presence in the abdomen. For this patient, we took him to the operating room. We had a takedown of his EC fistula, did a staple anastomosis, did a 1-stage repair with a 30 by 35 centimeter bioabsorbable mesh in peritoneal space. We know that he had 3 to 4 layers of previous mesh stacked in the retrorectus space, so we excised every mesh that we found this time. And then he subsequently had a delayed primary closure. This is what it looks like about 18 months post-op. His wife, that is primary caregiver, is no longer taking care of him as much as she had to, and now he's cutting logs of wood. The reason I presented this case was to talk about how we manage infected mesh, but also show that stacking multiple meshes in the same plane can actually be counterproductive. Next patient is a 53-year-old male who presents with a history of a liver transplant, who presents with a recurrent incisional hernia. He previously had a bridging repair with synthetic mesh, which recurred about 6 months later, and then had a peritoneal repair of his hernia again with synthetic mesh. This is what it looked like on examination. He had a 19 by 19 centimeter defect. A CT scan here shows about a 19 by 19 centimeter defect. Bowel tightly adheres to what appears to be displaced mesh in his hernia sac. For this patient, we took him back to the operating room also, did an open recurrent incisional hernia repair. We excised his previous mesh, rationale being that his bowel was tightly adhesed to the abdominal wall, so we had to actually partially circumferentially localize the bowel so we can take it down without any excessive bowel injury. We then proceeded to perform a bilateral TAR and place a 45 by 45 centimeter bioabsorbable mesh in this patient, and then close this defect. I used bioabsorbable mesh in this patient because at some point during this case, I did not think we would get the fascia fully closed, and I didn't want to put synthetic mesh in a situation like this. This is what it looked like post-op. And he's back to work as a butcher. Last patient is a 55-year-old male who presents with a 6-time recurrent epigastric hernia. He has had 5 different repairs in the past, complaining of 9 to 10 over 10 abdominal pain, some GI symptoms also. I called his previous surgeon that says he has a -10 pain threshold. He has been to the ED multiple times, in addition to the fact that he has stopped work and has taken time off work. His previous surgical history includes the open incisional hernia repair with bilateral oblique releases with surgimen mesh. He had a posterior fascial dehiscence and ended up having a robotic incisional hernia repair with intraperitoneal synthetic mesh. He's had a preperitoneal epigastric hernia repair with 6.9 centimeter synthetic mesh. A primary repair of the same defect a year later, practically recurs almost every year. Had 2 subsequent intraperitoneal mesh placements. On examination, he has a 2 centimeter wide epigastric defect. And a CT scan here shows about a 3 centimeter wide defect, possible onlay mesh still in place, some intraperitoneal mesh at the level of the level of the umbilicus, and some tightly adhesed bowel in that area. I haven't operated on this patient yet. It's someone I'm actually considering doing surgery on. The reason why I present this patient is to discuss the fact that sometimes the small defects can actually require more complex decision making and require more complex surgery. He obviously has a free retrorectus plane which can be used, but operation in this guy might require you excising all this previous old mesh all the way down to the ones at the paraumbilical region, requiring a true full abdominal wall reconstruction. In conclusion, one size does not fit all. Care is individualized and personalized. Plan appropriately and be ready to pivot. Thank you.
I'd like to call to the podium now Dr. Correa, who will be discussing iatrogenic abdominal wall injuries, denervation, avulsion, and atypical hernias.
Okay. Good afternoon to everyone. It's a great pleasure to be here. My name is Joana Correia. I'm from Portugal, and I work in the complex abdominal wall unit in Porto. And you asked for me to talk about how to plan your next complex hernia repair. In these cases, denervation, avulsion, and atypical hernias. So I have no disclosures, but I must admit I don't have a robotic system. We only have almost 15 robotic systems in my country, private and public. So I use open surgery for these cases. So we are talking about abdominal wall hernias, but not only about that, about abdominal wall dysfunction that are created by us or any kind of situations. But I think in these situations, maybe even you optimize very well, you correct very well, sometimes you don't have the perfect tissue and the perfect results at the end of the day. So you need to plan that and to allow a little bit the expectation of our patients. So talking about the denervations, the majority of the time are associated with an incisional hernia because of a retroperitoneal approach and can be a disruption of all muscular layers or all of a subset of one. In some cases, the external oblique maintains, but the problem is that we are cutting the motor nerves. So we have an incisional hernia, but we also have muscular atrophy, a bulging, and in some of the cases you have lots of surgeries after that with lots of meshes, so you have fibrosis and the more complex cases. And it's not only our urological guys that do that, our orthopedics with minimal invasive surgery, our vascular with AAA treatment, and ourselves, like in appendicectomies by perimedian incisions, for example, we are cutting all the lateral innervations, and because of that we are creating not only atrophy in the abdominal, on the lateral abdominal wall muscles, but also in the rectus muscle and creating that problem. But in another team, avulsion are associated in the majority of the times with the deceleration injury that can cause a single disruption of the abdominal wall or a complete one, but it's very rare. Almost only 1% in a blunt trauma, so we don't have so much cases in the literature. We understand that in acute phase, when we have a visceration, we need an emergency surgery. But when the surgeries collect all the data about this, they discuss a little bit that maybe it's not a good idea to correct right away this herniation because the patient are physiological derangement, we have contamination, we have loss of the tissue that are very bad. So in the majority of the cases, we only can achieve a suture repair in bad conditions and the recurrence rate are very high. So they discuss the possibility for a delayed elective surgery, but they alert us to not forget this hernia in the nearby. For example, in these cases, we have a partial avulsion of the rectus with lots of orthopedics problems. So our orthopedic surgeons try to fix the pubic symphysis and try to suture, but we do not treat the avulsion at this time. But I follow these patients, and now it's with 10 months later. In physical examination, I don't see any kind of herniation, and in the CT control, we seem it to be a little more fragile in the M5 portion, but it's not really nowadays a hernia. The problem is the majority of our patients are not in acute phase, they are in a delayed phase where already have muscle retraction, muscle atrophy, we don't have skin, and you have a hernia too. And in the last, the typical hernias. By definition, they are close to the abdominal wall margins, near the bone prominences, so more complicated. Some of them we already talked about because they are associated with the denervation. The majority of them are incisional ones. In my practice, I usually call the typical hernias to was another subgroup. The hernias associated with post-muscular resection like necrotizing fasciitis, desmoid tumors, metastases, or actinomycosis. I don't talk about the TRAM defects because it's another family, I think. But all of these hernias are associated with muscle defects, or the majority of them, and problems with bone landmarks, and lots of atrophy, for example, in this actinomycosis resection. So what are we going to do in our first appointment? We need to be aware that these hernias exist, that they are complex. They is not only a hernia, but an entire abdominal wall dysfunction. In the majority of the cases, maybe they are not so risky of incarceration. The problem is quality of life, and we need to understand if the surgery we are giving to them will give them that quality of life, and so lowering the expectation and be sure that the risk worth the reward. Of course, we are identifying all the comorbidities, risk factors, and optimize them. We already talk about that. And it's very important, the physical examination, and trying to identify not only where is the hernia, how big is it, if it's reductible or it's not because some kind of adhesions, if you are creating respiratory problems when you reduce that, if you have lots of other small wounds, for example, X-drains that are creating fibrosis, another small hole is distortion of all the anatomy. If you have enough skin or you have small skin, if you have like a very mobile abdomen like this lady, or a very rigid one, or things like radiotherapy, for example, that will create more risk of surgical site recurrence. And why we are doing that? Because we can decide because of that if we are using PPP, skin expanders, abdominoplasty, botulinum toxin, or incisional negative pressures. And the examination of the CT is very important also, not only because of the classification, the dimension, the loss of domain, and some kind of signs of risk for incarceration, but also the identification of atrophy, absence of muscles, destruction of semilunar lines, signs of other kinds of surgery that damage other planes, and problems with the mesh. And why? Because you can decide preoperatively if you are using toxin botulinum, if you are using PPP, intra-op vertical traction like fascia tens, and because you are already planning your surgery before it. You are expecting a harder surgery with more time to dissect in cases of atrophy and absence of muscles. You understand that with atrophy you don't have a very good muscle movement to the midline. If you have destruction of the semilunar lines, you need to reconstruct them, and you need to overlap that with the mesh. And in some cases you need to think not only in the second and the third plane, but also in a second stage approach, for example. But they are so different, or they are the same when we are talking about strategy. I think all these three kinds, I think the strategy can be more or less the same. All of them have a defect. The majority of them have denervation and atrophy. They are associated with bone structures, loss of muscles. We are dealing with the extremes in the abdominal wall. So I think the principles are more or less the same. Saving the hernia sac till the end because you may need that. Increase the mesh density and a very large overlap, and with that trying to overcome the denervation and atrophy. Prefer the preperitoneal, pretransversalis, retromuscular plane if you have that, and anchorage to stable structures, and try to overlap with mesh that anchorage in order to decrease the risk of recurrence in that zone. And to do that, you need to plan your surgery, and you need to study very well not only the regular abdominal wall anatomy, but the anatomy of the extremities of the abdominal wall. For example, be careful with the nerves. Identify them, not cutting them, preserve, and not create situations of chronic pain. And this not only in the pelvic part, but also in the lateral retroperitoneal part. And sometimes you have lots of nerves. Sometimes we are not able to see them so well because they are similar to other structures. So be careful of transfacial sutures, for example, and not passing through them. And be careful with the diaphragm. For example, we know that it's a continuous of transversus abdominalis, and with fibrosis, atrophy, and lots of dystrophy, it's easy to create some tears in the diaphragm. You need to understand that we are creating them, correct them, and overlap them with a mesh is better now than after. Be careful with the heart when we are too cranial, and be carefully with all the vessels when you are in M5. And have a second and a third plane. I must admit that I'm a little bit old-fashioned and I like to write on a paper all of my planes. And this is important because you need to have appropriate devices, not only for your first plane, but for your second and your third. And sometimes this is a complicated situation. Maybe you need to have some friends of other specialties on call if you need it. And for devices, I'm talking about to have a broad spectrum of densities of your synthetic mesh available, but also sometimes biosynthetic, hybrid, or other kinds of mesh that it's needed by that situation. And negative wound pressure therapy for closed wounds, but sometimes you can need, you may need not to close at the first time and use negative pressure over the tissue or over the mesh, and you need to do that. And you need to have suture bone anchors and sometimes intraoperative traction too. So my take-home message for planning is having an open mind to identify the hernia, but also the entire abdominal wall dysfunction, trying to understand the impact in quality of life of your patient and be a realistic result to them, optimize the patients, study very well the anatomy of your hernia, of your patient, of the extremities, of your CT scan that will give lots of informations for the surgery, using big mesh with higher densities, macroporous, and anchor them to a stable structures, and try to close the gap with muscle, or if it's not possible, maintain the sac till the end to close that. And if you need it, ask for help because the patient is your priority. So thank you, and if not before, see you in Paris next year.
Fantastic. So Antonio's going to come up and talk to us. If there's a more influential plastic surgeon in the world in abdominal reconstruction, I'd like to know who that is. And so Antonio's on the American Hernia Society board and has lectured around the world in abdominal wall reconstruction and in all facets in that. We look forward to your comments.
Thank you, Henry, for the introduction. Good afternoon, everyone. I am going to take the next 15 minutes of your time to talk about soft tissue considerations in patients with ventral hernias. I don't have anything to disclose, just to let you know that all the pictures and videos that you're going to see are from patients of mine. So I am going to talk about two main situations, excessive soft tissue and lack of soft tissue. First, I'm going to talk about excess soft tissue. It turns out that when we ask hernia patients what it matters the most to them, the thing that concerns them the most is the way they look. Symptoms or the possibility of gastrointestinal complications is not number one. The number one is how they look. And the newest quality of life questionnaires that we use in patients with hernias include items such as symmetry, attractiveness, how you look when you wear clothes, what's your appearance. So these are outcomes that we might target when treating our patients. So hernia surgery is a great opportunity to not just close the muscles, but also to address the problems in the skin and the fat and perform total abdominal wall reconstruction. And to do that, I like to bring as much as I can the concepts of a cosmetic abdominoplasty to a paniculectomy in an abdominal wall reconstruction patient. So the thing that I have to do is to plan which type of paniculectomy I am going to perform in any given patient. And in order to know that, I have to take into consideration several situations. First, where is the excessive skin located? Is it in the central, in the lower, in the upper, all around the core? Where are previous scars located that may interfere with the blood supply? and also where the hernia itself is present, where I might find a thinned out, devascularized skin after reducing the hernia sac, and that's exactly the skin that I might want to remove. And also the presence of other entities in the skin, like ulcers, extruded meshes, or stomas that may make me lean towards some type of paniculectomy or another. Now, paniculectomies have existed for decades, and I can tell you that there are dozens of different types of paniculectomies that have been described, but there are 5 types that are probably the most useful for all of us to know in the subset of hernia repair. The first one is what we call conventional paniculectomy. It involves the removal of the lower half of the abdomen. It leaves a scar very low in the abdomen where it can be hidden by regular clothing. And in order to leave the umbilicus in the position where it needs to be located, we have to incise the skin around it, and the blood supply to the umbilicus will be formed by the myocutaneous perforators that, as you can see in the left side, they travel from the muscle up to the skin, and as you can see in the right side, they are coming from the medial rows of the deep inferior epigastric vessels. So if we want to preserve the skin of the umbilicus, we have to avoid placing sutures or making cuts where the yellow lines are present, because that's where the blood supply to the umbilicus is going to be preserved if we made an incision around the umbilicus. And these are the types of results that we can expect. This patient has umbilical hernia and rectus diastasis. This other patient has an incisional hernia in the lower abdomen. This patient has a larger type of more complex defect, and they have been addressed with a conventional paniculectomy. Now, in this particular patient, the hernia is located in the upper abdomen and the mid-abdomen in the right side. So I don't want to remove the skin that is below the umbilicus and leave that devascularized skin. So I might as well perform an upper type of paniculectomy, extend the excision to the other side, to the left-hand side of the patient, and then leave only very well vascularized thick skin in the patient. And of course, he will have a higher scar, but I will address the problem properly. Now, if you feel that the skin of the umbilicus is so thin that the blood supply is coming mostly from the subdermal plexus, then we have 2 options. One is to just go ahead and remove everything and plan for an umbilical reconstruction in the future that can be performed in the office. The second option I will show you a little bit later. So the second type of paniculectomy is what we call mini paniculectomy. It involves a shorter excision and also narrower. And now you don't have to incise the skin of the umbilicus, but rather to disinsert the umbilical stalk. So now the blood supply will not come from myocutaneous perforators, but from the dermal plexus around the umbilicus. And in order to have access to the entire abdominal wall and address hernias and diastasis, usually we have in the abdominal wall reconstruction patient to extend this mini abdominoplasty more laterally. So these are the type of results that we can expect by doing this. And this is the second option that I was going to let you know about when having very thin umbilical skin. This patient, it looks like I can remove a lot of skin from the umbilicus down, but she has a very narrow, a very short distance between the xiphoid and the umbilicus. So maybe I am going to have to pull down a lot of distance, and I am going to give her a very hard postoperative course. She's 75 years old, so I rather prefer to do less high of the resection of the skin, do this extended paniculectomy, and then make an incision, a vertical incision below the umbilicus. And by doing this, I don't have to bring the umbilicus down to the pubis. I leave the umbilicus where it has to be left, but I have to make this inverted T type of resection, which if it doesn't extend all the way up to the xiphoid, it might not impair the blood supply. And this is the before and after pictures. Third type of paniculectomy is what we call circumferential or bell lipectomy, mostly performed in patients with massive weight loss. Fourth is a vertical paniculectomy, very helpful in ventral hernias, patients with already previous vertical scars. This is an opportunity to remove the previous wound and make a new one, and also to remove extra skin. If there is more skin in the lower abdomen, you can draw it as a teardrop. And the good thing is that you don't have to sacrifice myocutaneous perforators, and this is a good option for patients with high risk factors for developing postoperative complications such as smoking, radiation therapy, and all that, and you will be able to get an improvement in the contour at the expense, of course, of a vertical incision, but sometimes this is an opportunity to make the new scar better than what they had previously before the surgery. Last type of paniculectomy is a combination of vertical and horizontal paniculectomies. This is not new, as you can see, and these are variations. The fleur-de-lis, the one in the left, involves also removal of skin in the pubis, and the right one is the Mercedes paniculectomy. It leaves a scar in the form of a three-pointed star. I use this in patients with excessive skin in both directions, the horizontal and the vertical direction, but also, like in the lower patient, the picture in the lower part, patients with excessive skin in the lower part that have previous paramedian scars that I want to move towards the midline. And this is the type of result that we can have from a combined vertical and horizontal panectomy. For the closure, I advise to use quilting sutures that reduce the time that drains have to be there in place. Trim out the edges of the umbilical skin to see if it's going to survive. And at the end, I can just touch up a little bit the incision, the final incision, to make sure I end up having a very nice curved line. And the use of incisional negative pressure wound therapy has lowered the risk of dehiscence. Now I'm going to change gears to talk about the lack of soft tissue. So the good thing in the abdomen is that we usually have excessive skin, and the tissues here are very, very pliable. So when I take a look at this wound and I think, where will I move tissue? Where I am going to bring a flap to cover that hole? I think we have to remember, and maybe this is going to be like the best takeaway home information that I can give you all this afternoon, is that we can actually extend the size of the defect and perform something very similar to what we do when we perform abdominoplasties. Most patients are candidates to perform breast reconstruction with abdominal base flaps, and we remove the lower half of the abdomen to perform breast reconstruction regardless of their body mass index. So most patients have an excessive, I have seen in the hall some patients that don't, some people that don't, but usually most people have some excessive skin that we can remove. And as you can see here, I might as well remove all that skin and fat, dissect towards the xiphoid, bend the table, and be able to close this. And of course, I can give her umbilicals in the office as an office procedure and address all the lack of soft tissue that she had. But what happens if after performing this maneuver, it doesn't close? There is always the possibility to consider local wound care. Negative pressure wound therapy is the cornerstone in the abdominal wall for local wound care. And this is true particularly if wounds are small and they will heal fast, or if there is active infection and I don't want to cover it just yet, or if surgery, a long surgery is not an option because frailty of the patient, of patient's desire. So if it doesn't close and the patient is not frail, infection is controlled, wounds are large and will take too long to heal after local wound care, or if there is exposure of vital structures such as mesh, grafts, or viscera, then we, the plastic surgeons, have some reconstructive tools. And these are mainly skin grafts and flaps. A skin graft is a piece of skin that doesn't have any blood vessels, so it needs to be placed in a very well vascularized area. In the abdomen, it has to be either muscle or granulation tissue. So after wound care with negative pressure wound therapy, like the patient that you see in the left side, I have a granulation tissue and I can place a skin graft and provide coverage. A flap is a segment of tissue that has its own blood supply, usually an artery and a vein. And I use it when I have a very huge defect, like this patient that had both rectus muscles removed from a carcinoma that she had in the abdominal wall. So if I just place a bridging mesh, she's going to be left without any function. And so I need to provide some functional tissue. So I bring this flap with its own blood vessels and its own nerve. This is taken from the back. It's a latissimus dorsi myocutaneous flap. And I suture the thoracodorsal vessels to the deep inferior epigastric vessels. I also suture, you can see on top of that blue piece of paper. I also suture the thoracodorsal nerve to one of the nerves in the abdominal wall. I can place a mesh behind that muscle and the remaining muscles of the abdominal wall, and I can suture it all and provide full muscle coverage of the mesh. I leave this skin island for postoperative monitoring of the blood supply of the flap. Let people take pictures after the end of the surgery so that I can show them here. And this is 1 year and 2 years after this tumor removal, after this reconstruction, and after radiation therapy that this patient needed to have as part of this oncologic problem. Now, I have been asked to talk about tissue expanders. These are deflated implants that we can inflate either with air or with solution, and as they grow, they make the tissues that cover, they make them grow. In the breast, for breast reconstruction, they are very popular because they are associated with great outcomes. In the abdominal wall, they have not been that awesome. They can be placed inside the abdominal cavity for giant omphalocele or before small bowel transplantation, but they have been associated to urinary obstruction, small bowel necrosis, or even death of the patients from expander infections. So they are not used a lot, although you can see the last reference is not that old. They can be placed in between the muscles for hernia repair or for omphalocele. Not very popular because there are better options than these ones, but you can also see here very recent references showing this. Probably the most popular use they have is behind the skin subcutaneously to make some healthy skin grow and make these scars or skin grafts removed and reconstructed. I will place them here to advance healthy skin. So in conclusions, with regards to excessive skin and soft tissue, panniculectomy targets patient-reported outcomes and improves quality of life, and the type should be tailored to particular patient's conditions. And with regards of lack of skin and soft tissue, we have to consider abdominoplasty type of tissue advancement, negative pressure wound therapy for small defects, skin and flaps for large defects, or exposure of viral structures. Thank you very much.
That was phenomenal. Oh my gosh, amazing. What a flex, exactly. I'd like to invite Janice Sacco to talk about concurrent procedures, visceral resections, oncologic resections, GYN and GU. Yep.
Thank you very much for the invitation and for the opportunity to present. That was great. I'm sad I have to follow it, but hopefully this will be interesting for you all. Just more aggressively. All right, these are my disclosures. And so what I'm going to talk about is I want to first start with some general planning and considerations for these operations, and then I'm going to go through some cases that I've done in the past couple years to kind of use as examples for how we plan for these cases. And then I'm going to end with talking a little bit about planning these cases with multi-surgeon approaches, because many of them do require many services. So it's really all about planning. Eric started the session by saying that you need a plan, and I think many of the presenters have mentioned that you really need multiple plans. If you get to plan Z, that's okay. Just make sure you have plan A number 1 for the next list, because especially with these complex procedures and multiple procedures, the more procedures you're doing in the operating room, likely the more variables there are, and the more possible complications that can occur, and more likely that you're going to need to pivot and do something differently than your maybe best option. So we're going to kind of break this down into 3 things, which are the preoperative optimization that we can do for patients, the intraoperative considerations that we need to make, and then the postoperative concerns that we really should be predicting ahead of time. So we want to define the goals of the operation. I think that's always very important in hernia surgery. I've heard many of the speakers in this session and others talk about quality of life and what is important for the patient. And what becomes a little bit more difficult, I think, in these combined procedures is the goal is not always, or the first goal is maybe not always the abdominal wall reconstruction. We're going to talk about patients who maybe have a malignancy and maybe that's really the main goal. And sometimes we as the hernia surgeons kind of become the second or the third important line. So you're the one that has to pivot more because the oncologic surgeon is going to do what they have to do to treat the cancer, or the colorectal surgeon is going to do what they have to do to reverse the colostomy, and we're the ones left kind of trying to figure out what our next plan is. So there's many, many things to think about. This is not an inclusive list, but I think the preoperative optimization, as Bola mentioned and many people, I think is extremely important. And I think the more complex the case, probably the more important it is. So we really strive to optimize our patients from their comorbidities. Their functional status is super important. Physical therapy has been great in our program for helping our patients get ready for surgery. Just a simple walking program. Dr. Henneford's group showed how beneficial that can be, how important nutrition can be, what labs do you need, does the patient need TPN to get their nutrition, and then what's the timing of surgery? You know, if this is an intercutaneous fistula or if this is a mesh infection, or depending on what you're doing, do you need to wait some time or do you need to get there quickly because this is a malignancy? Intraoperatively, it's really all, I think, there's a lot of big things, but it's all the small things. How's the patient going to be positioned? What do your colleagues need? Are there going to be multiple OR teams? Do you have your own table and your own tray of clean instruments so that you don't have to use what the colorectal surgeons just use to resect the colon? And really, you know, what are they planning, and making sure that you both understand what the plan is. Where is the incision going to be? Where are they going to extract whatever specimen they're removing? You know, I think one thing I definitely learned from Kent Kircher was no matter how small the combo case, make sure you make the incision. If they want you to close the 2 centimeter umbilical hernia at the end of their big robo case, make sure you get in the belly for them so the incision was yours and you know what you're doing at the end. You know, and then what are they resecting? You know, they're mobilizing the colon. Are they going to get into your preperitoneal plane or into your TAR plane? You know, you may have to spend your day there kind of making sure that everything that they're doing, if obviously the oncologic resection comes first, but, you know, making sure that what they're doing is in conjunction with what you need to do afterwards, because obviously we're usually the second part of the operation. And then obviously, like we just talked about, the order of importance, right? Again, the hernia is usually the least important in the grand scheme of things, or at least that's how it seems sometimes. So, and then postoperatively, who's going to be making the decisions? Who's in charge? What floor is the patient going to go to? What are you going to do with antibiotics? Does the patient need anticoagulation? Are you using their ERAS protocol or your ERAS protocol? Or does the patient, you know, not fit into the ERAS protocol at all and you need to do something differently? These are all things that you cannot decide as you're going along. You need to have all these planned out. So this is the first patient I want to talk about. This is a 66-year-old lady who was seen by my gyn-onc colleagues. She had a recurrent ventral hernia, and then she had this extremely large adnexal mass. It was causing a lot of pain. It was obviously discomforting, and there was a concern that this was a malignancy. Because there was a concern for the malignancy, you know, you can see that she had a poor functional status. She was obese, but kind of how much can we do about that? She already got a DVT from the compression of her IVC and a PE and was on anticoagulation for that. So then we talk about our considerations, right? So time constraints. She needs to go to the OR. I don't have 6 months to get her to lose weight and get her functionalized and do things. But that doesn't mean we can't do anything. You may have noticed in that first picture, there was a wheelchair in the background. She came into my clinic in a wheelchair. On the day of surgery, she walked into the hospital, even though it was only 4 weeks after I met her. She walked every day. Her family was on board. Everybody understood what was going on. We sent her to physical therapy to get on just a simple walking program, but she just couldn't do it at home. We did have her admitted the day before and had an IVC filter placed because of the concern for blood loss with the gynonc portion of this operation. So then intraoperative considerations, right? Like I mentioned, always start and finish. I always make my own incision. If you saw the massive tumor, I was not concerned at all about getting her abdominal wall closed. It's kind of despite if you look at her scan, she maybe had some loss of domain. When they took that mass out, I had gain of domain. There was it was very lax and it all came together beautifully. This is a contaminated case, so I think we could spend the whole time talking about mesh choice, but for me, that's a biologic mesh anytime it's a contaminated case. I always have a completely separate closing tray and clean instruments anytime it's a contaminated case. We change our gloves, we redrape, we get new light handle covers, new suction, new bovie, the whole shebang, and that's, again, something that you don't want to be asking for as you're scrubbing in. That's something you want ready to go, and you're ready to scrub back in, and here you go. The other thing to keep in mind was I did all the lysis of adhesions for him, and I actually helped him mobilize the mass off the lateral abdominal wall because I wanted to be sure that I had that pre-peritoneal plane to put my mesh in and I wasn't closing a bunch of holes that were unnecessary. Obviously, if it's malignant and it's involving the peritoneum, it's got to go, but if you can save it and you're there to tell them that you need to, then it's a lot easier for you later. Post-operatively, with her medical history, we did just plan an ICU admission. The gynonc team was really managing things, but we're obviously closely following and really taking care of the wounds. We waited for a while for her anticoagulation, and that's why she got the IVC filter. So what did we do for her? There was a lot of lysis of adhesions. The bowel was very stuck to the mass, so I did most of that. He resected the mass. He did a total abdominal hysterectomy as well as a BSO, and then I did a pre-peritoneal repair. Like I said, did not need a component separation. The fascia came together very easily, and we placed a large biologic mesh in the pre-peritoneal plane. She went home on post-op day 7, walking, mobile, didn't need to go to rehab. I think a lot because of even though short rehab, that advanced on its own. Short stint of prehab that she had really helped us. Her final pathology was borderline, so she thankfully didn't need any further chemoradiation. So I tried to jump the gun, but next I'm going to talk about 2 different enterocutaneous fistula cases that required bowel resection, obviously. The first one, this was a 36-year-old female who stabbed herself 3 separate times. The first time she required a transverse colon resection, a small bowel repair. She actually healed well and did fine from that, and then about a year and a half later, she stabbed herself again. She came in at that point, just had a colotomy repair, but unfortunately, about 4 to 6 weeks later, she stabbed herself again, and at that point, her abdomen was pretty frozen, not really much that could be done, so a controlled fistula was created. She was admitted to the psychiatric facility for about 2 years before I met her. When I met her, she did have a low output fistula. She was actually tolerating a regular diet. She had a pretty good nutrition status, actually. This is a patient kind of on the other side of the spectrum. So this is a 60-year-old truck driver who had a Hartman's procedure. After the Hartman's, he got a peristomal hernia that was acutely incarcerated, required an emergent operation and a bowel resection. And then he went to get a colostomy takedown and had a small bowel injury had a leak from the colostomy site as well as a small bowel injury requiring back to the operating room for a diverting loop. Then that still got infected again, and he had abdominal wall debridement, requiring a open abdomen for a while, eventually a vicryl mesh and a skin graft. He shows up in the clinic. He doesn't really know how much is coming out. He's a truck driver. He's just trying to make ends meet, and he's got to go to work, and he really doesn't empty or control his fistula. He had some intermittent, looking back in the chart, some dehydration admissions. So I'm like, all right, let's get some labs, quantify your output, come back in, a couple weeks. I immediately get a call from the lab that his creatinine's 10. And so, we kind of fairly urgently admit him to get him optimized. So kind of going back to our first lady, what do we need to think about from this preoperative optimization, right? Her nutrition's actually good, so that's great. We made sure she was on some high protein diet. and we were controlling her fistula. She had a sizable hernia, so I had to do preoperative Botox for her. And really, the biggest thing for me was her psychiatric optimization. I saw her for probably 8 months, where they were trying to convince me to do this operation, and I was like, "Are you sure she's not going to do it again? Because, like, you know, this is a one-time thing, and we can't keep doing this." And for the other guy, you know, it was a lot of pre-optimization. He obviously was extremely dehydrated with his high output fistula. We had to admit him to the hospital to get him rehydrated, get him on TPN, get his output down, right? You cannot really take care of these patients if their outputs are 3 and 4 liters. It's not gonna work. I like to use Imodium and then Lamodal, and then I had octreotide. Octreotide can sometimes be a battle with the insurance company, but it's worth those phone conversations to get it approved because it typically works good. He was smoking half a pack of cigarettes a day. He completely stopped smoking, had a negative urine nicotine screen. He did, even though we got him on TPN and even though we got his fistula output down, he continued to have admissions for dehydration. We had to add fluids to his TPN, and he was really actually quite difficult to manage while he was trying to drive his truck and just pay his bills. Lost insurance a few times, and just really hard to find back in the clinic. So for him and her, I did a 1-stage repair. I kind of believe in what Dr. Henneford often told me, which was do it once, do it right, and try to never go back. We did delayed primary closure for both of these patients as well. So that is her, just 1 bowel resection, and then that was him, where thankfully the DLI and the fistula were together. 2 more quick cases. This is an abdominal wall desmoid. So my surgical oncology colleagues that involved me for this, involving most of that rectus, as you can see. This is a 24-year-old girl who got a sleeve gastrectomy and lost 300 pounds and then said, "Oh, wow, this is a big mass." So the big thing for her was, again, we did have a biopsy suggesting this was probably a desmoid, but hard to tell. And not sure it's a sarcoma, so we don't really know. Is she going to need radiation? Is she going to need excision? We did discuss a paniculectomy, but not something that we felt was a great idea at that time, not knowing what she would need post-operatively. Now, the other thing, we had a really great session this morning on female hernias. This is again, I said a 22-year-old female, so she desired future pregnancies. I did not want to put in a large synthetic mesh in her, so I preoperatively Botoxed her, and I put an absorbable mesh in the preperitoneal plane, not violating her retromuscular plane. She did great and went home on post-op day 2. So these are the most common abdominal wall masses, desmoids, sarcomas, and then can be metastasis. There's actually a great chapter that Bola wrote with some of our other colleagues from Carolina on classifying this, and she was a 1C with a full thickness muscle tumor. So then a colostomy reversal. This is a case I actually just did on Monday, previous Monday. And this gentleman had an attempt at a colostomy reversal. Didn't happen, online peristomal hernia repair. And now he really wants his colostomy reversed. So my colorectal colleague says, "Yes, I think I can do this. Can you help me?" I said, "Of course, but are you going to be able to do this? Are you not going to be able to do this?" He doesn't know, obviously, so I got to be prepared for the colostomy staying in place. I got to be prepared for the possibility that he doesn't love his anastomosis and he wants to do a diverting loop. Again, I really want to try to do this all at once. And so we were able to thankfully reverse his colostomy, but we definitely were prepared to do a peristomal hernia repair or just do the DLI and kind of come back for a second operation. Again, very similar to the other contaminated cases, wound protectors, closing trays. And for this patient, I chose to do what I would call a French fry vac. I didn't feel like he needed a DPC because everything was pretty contained, but I also didn't want to close that colostomy site completely. So we placed these wicks of the black sponge, and then we change it on the floor to an incisional vac on postoperative day 3. And then with the last minute here is a case that I actually haven't done yet that got canceled because the patient came to the preoperative area with osteomyelitis of his finger and used our OR to get that debrided. You can't make this stuff up, but so this is a gentleman, ventral hernia, peristomal hernia, and a ureteral stricture. He had an open Hartman's. He got a ureteral injury. They fixed it, but he still has a stricture and he requires a percutaneous nephrostomy tube. So urology wants to do an ileal ureter. I said, "Great. What is that exactly? And how are you going to do that? And what are you going to do if you can't do it?" And that has own question of its own, and for him, the answer was a nephrectomy, but the other option really is a PERC nephrostomy. Either way, we need to also account for the fact that they may not be able to do their portion, and then the colorectal surgeons were going to reverse his colostomy, and so again, I have to plan for the fact that maybe they're not going to be able to do that, and maybe I need to do a peristomal hernia repair. So that's our plan for him, and I guess once he gets better from his osteomyelitis, we will see what happens with him. The last thing I really want to talk about is just playing nice in the sandbox, and it's not easy, and like I said, often we are the kind of second fiddle or maybe not as important as the other operations, and I think that's okay. We just need to recognize what is the goal for the patient and what's most important at that time. But it's really important, I think, to have these everything planned out, right? It's much easier if everybody's on the same page and you guys all know exactly what you're doing. And then I would just like to invite all of our female hernia surgeons to the Limitless Summit in February. Thank you.
So next up would be Bonnie Lee. She's right there. We go. Talking about one of my favorite things is Botox and pneumoperitoneum.
All right, thank you so much for this opportunity. No one wants to pay me. So Botox and PPP are useful adjuncts in complex hernia repair when we're dealing with non-compliant abdominal walls, when we're downstaging large hernias and want to avoid component separation, and in loss of domain cases. With loss of domain, you have viscera that doesn't fit within the confines of the fascia of the abdominal cavity, so you'll want to use Botox and or PPP to decrease the risk of compartment syndrome, decrease the tension on your repair, increase the likelihood of fascial closure, and to decrease the risk of hernia recurrence. So before you start offering Botox and PPP, you'll want to consider whether doing a hernia surgery is actually in the best interest of the patient. I always counsel my loss of domain patients that if that there is a risk of abdominal compartment syndrome, and if they're not okay with the risk of death, that maybe the better option is to spend the rest of your life with an abdominal binder. So how do we determine loss of domain? There is no standard definition for loss of domain, but I use the Tanaka index. Alternate methods include the Sabig's method or the Reams ratio. I'm probably slaughtering those names. This is the original paper describing the Tanaka index, which uses the formula of the hernia sac volume divided by the abdominal cavity volume. And basically, if the visceral volume is outside of the abdominal cavity is 25% or more, then that is loss of domain, and that's the cutoff that I use to Botox a patient. Here is a demonstration of how they calculate the Tanaka index. So the small a, b, and c are the dimensions of the hernia sac, and capital A, B, and C are the dimensions of the abdominal cavity, and the formula is on the top right over there. Sabig's method also uses CT scan, and they actually use tri-dimensional CTs. This requires specific software, and their cutoff for the volume ratio is actually 20% as opposed to 25%. Reams ratio uses a freehand ROI tool, longitudinal view, or an ellipse on the axial view to measure the surface areas of the hernia and abdominal cavity. Their findings do correlate with the Tanaka and Sabig reference ratios. Below is the website that should let you use those tools. I personally did not have any luck with that, but maybe others will make it work. So now that you've determined that the patient has loss of domain, you can use Botox and the Botox will relax the muscles temporarily and allow the abdominal wall to expand. There's multiple protocols floating around for Botox. Botox is not actually FDA approved for this indication, so we don't actually know the best or safest use or best or safest dose. Some people will inject all 3 muscle layers. Some people will inject only the external oblique and the internal oblique. You'll want to make sure that you omit injecting the transversus abdominis if the patient reports back pain, since this muscle does have a role in stabilizing the thoracic spine. I will note that it doesn't seem like there's any worse outcome if you only inject the external oblique and internal oblique as opposed to doing all 3 layers. There's a lot of variability in how much Botox people use. I've seen as little as 150 and as much as 500 units at 3 to 5 injection sites per side. If you decide to use Dysport, you'll want to use 3 units for each unit of botulinum toxin A, and just know that the Dysport will spread more than the BTA. So in terms of timing of Botox, most people inject 2 to 6 weeks preoperatively. You'll see the maximum effect of the Botox at 2 weeks, and this effect will plateau and last for a couple months thereafter. I do my own Botox injections in the clinic because IR at my institution was too busy to do it for me. So I usually inject 150 units on each side at the points shown here. On the right, you see a picture, which is actually taken from a tap block, but I actually think that it really nicely shows the anatomy that we look for when we're injecting the Botox. The Botox injection is much easier on ultrasound guidance than compared to a tap block because you're just trying to inject the muscles and infiltrate the muscles rather than trying to target between the fascial planes. So this sample Botox protocol was lifted from this 2017 paper, and they use 300 units of Botox, and they're injecting 25 cc's in each of the 6 spots. I tend to use less volume for my injections. Here's another sample Botox protocol. They're using 200 units of BTA or 500 units of Dysport, which comes down to 33 units of BTA per injection or 83 units of Dysport. They're injecting 15 cc's at each of the 6 sites, and they're doing this 3 to 4 weeks preoperatively. Here's a side-by-side comparison of a couple different Botox protocols. You'll see that there's differences in the concentration and volume of the Botox being injected. I think I actually lifted some of these protocols from Dr. Espinoza's slides at a different conference, so thank you. In terms of the equipment you need for ultrasound-guided Botox, it's pretty straightforward. You want or any local really to anesthetize the planned tract, and you'll want a needle that's 21 gauge or thereabouts and 7 centimeters long. You may need a longer one if they're obese. And you really want to just watch your needle go into the deepest muscle that you plan to target, watch it infiltrate, and continuously inject as you're pulling back. So I will counsel patients that they may get bloating or distension 2 to 3 days after the Botox injection. They may also develop a weak cough or a weak sneeze, and I do notice that the tar planes are stickier after I inject the Botox. Is there any data that shows that the Botox works? This 2017 paper by the Australians showed that they had abdominal wall lengthening of 4 centimeters per side. That was on 32 patients. There was also a meta-analysis done in 2021 of 995 patients, and they showed a lengthening of 3.2 centimeters per side. This is a picture showing the improvement in the abdominal wall length before and after the Botox injection. The patients here they were measuring it in both the resting position and also as they're performing a crunch. Now turning our attention to preoperative progressive pneumoperitoneum. This is done by putting a catheter intraperitoneally and then insufflating the abdomen with room air daily or every few days until the patient reports that they're uncomfortable or having difficulty breathing. This gradually stretches the contracted abdominal wall muscles and increases the capacity of your abdominal cavity. This also helps prepare the patient physiologically for the abdominal hypertensive syndrome that they may develop post-operatively. There is no clear recommendations regarding the optimal duration, frequency, or the right volume of insufflation for PPP. So because of this, there's a couple different methods that have been discussed. Shout out to Drs. Mandujano, Dr. Espinoza de los Monteros, Dr. Shinde, Dr. Fernandez, and Dr. Punjani for their protocols, which they have posted on the IHC. In terms of catheter insertion, you can use a tunneled 9 French catheter placed during diagnostic lap. You can have IR place an ultrasound guided 8 French pigtail. You can also do an ultrasound guided placement in office using a Varus needle with Seldinger technique. You put in a little air, get a chest x-ray to confirm good placement and that you see pneumoperitoneum, and then add additional air while the patient is in your office. This can be done inpatient or outpatient. Inpatient is usually done in the US and in Europe and South America. They'll do outpatient is what I tend to see. You add air via a three-way valve until patient is uncomfortable. Usually this is 800 cc's to a liter. And you can insufflate until abdominal cavity volumes match the hernia volumes, or some people will do 3 times the hernia volume. You can start a few days before surgery or 2 weeks before, and to prevent DVTs, you'll want to use heparin or Lovenox and encourage the patient to walk. Here's a picture of a diagnostic lap placement of a tunneled intraperitoneal catheter, and you can see the 3-way valve that they're using to instill the room air. Here's another picture of air being insufflated into the abdomen. So is there any data that proves that PPP works? This 2021 paper also by the Australians showed that after Botox, they had a 3.2 centimeter increase per side, and then when they did PPP after the Botox, the total length per side increased to 4.4 centimeters. This is another paper done in 2021, which showed that after Botox plus pneumoperitoneum, they had an increase of 4.8 centimeters per side. So PPP is not benign. You can have subcutaneous emphysema afterwards, pneumothorax, pneumomediastinum, pneumocardium, metabolic acidosis, respiratory decompensation, and DVTs and PEs. Here is a picture of a patient who developed pneumoperitoneum, subcutaneous emphysema during PPP, and these pictures are courtesy of Dr. Katie Schlosser. In terms of whether you use Botox or PPP or both, if you're going to use PPP, I do recommend using Botox beforehand, because that way the Botox will temporarily relax the abdominal wall muscle so that you only need to start the PPP a few days beforehand. However, given the complications of PPP compared to the relatively minor side effects of Botox, I tend to not use PPP in my practice, and I stick to Botox. However, there are many surgeons who have used PPP with good outcomes. So just anecdotal evidence from my own clinical practice. These are what my loss of domain cases usually look like, and I have good success with Botox alone plus a component separation. But sometimes you do run into patients like this. This patient was elderly, a cirrhotic, and he did not have much mobility at baseline. So I really did not want to use PPP on him. So I ended up using just Botox with TAR, and I did have to use a peritoneal flap herniaplasty on him. But he miraculously survived the surgery, and I was pretty happy with his relatively snatched waist afterwards. So here is a comparison of how he looked pre-op and after the surgery. That's not actually a belly button because I had to excise it. He just had a wound necrosis where I basically made that fleur-de-lis incision. But, you know, it kind of looks pretty good afterwards. So that's all I got. Thank you so much.
I was going to ask you a quick question while you're up there. While you guys are coming up to the microphones to ask questions, I actually had one for Bonnie. That was an awesome talk. I was wondering if you could comment for the audience about how you approach this, since it's an off-label use. Do you counsel your patients? Do you document in a specific way?
I probably should. I don't. But I think that's a really good idea to tell them that it's off-label. However, since Botox doesn't really, have many bad side effects besides those kind of minor ones that I talked about, I don't think it's all that concerning, but, I do talk about the risk of going intraperitoneal and hitting viscous and all that.
I'm going to ask a quick question. We'll go to the audience. Jana, you were pretty specific about these combo cases, and in the cases that have a higher risk of infection, your mesh choice. And so I'd like to ask other members of the panel, perhaps Antonio and perhaps Eric, if you have someone that has a history of possible cancer, possible need chemotherapy may save their life, contaminated case, how does that impact your mesh choice? The two of you guys quickly, and then we'll go to the audience.
Oh, well, all right, well, he's got the mic. I might not use any mesh at all, Todd. I mean, I might actually disclose somebody either primarily or with some mesh suture and live to fight another day, especially in those EC fistula cases. I don't mind if they get a small hernia down the road, and then I can, then I have weapons free and I can use whatever mesh I want.
Yep.
In my case, if the patient is healthy, doesn't have any risk factors for complications, I might use a large pore polypropylene mesh. But if the patient takes steroids or has diabetes or is obese, then I'd rather not use any mesh and expect for some recurrence and do it when it's a clean case.
I think Janet was really, I loved it, but she kept saying, but if, planning ahead and what the other people, they may have to do to get the case done. But if it's cancer and the patient may need chemotherapy to save their life, I think we need to be very careful about that. How about, let's start over here.
Mazen Al-Mansouri, University of Florida. Fantastic session. Sometimes no matter what you do, you end up with a hernia that you just can't close. And the question here, I guess, the options are, do you either bridge and just accept that there's not going to be muscle over your closure, provided you have good skin and soft tissue coverage. The other option is to do a free flap, but that also adds significant time to the case and significant morbidity to the case. Is any of the panel aware of any comparative data to compare bridging alone versus using flap to aid in closure?
I don't know. I think I'm not aware of any study. I think it is a matter of the size of the defect that is going to be bridged. We all accept some amount of bridging if it doesn't feel like it's going to impair the function of the patient. But if 1/2 of the abdominal wall is missing, in my practice, I add a free flap because it provides function that otherwise will not be there if it only has a bridging mesh. A mesh is so thin that it acts as a huge diastasis. So if the bridging is going to be small, I accept it. If it's going to be 50% of the abdominal wall, I will do a free flap, but I don't know about any comparative study available out there.
I'm not aware of any study. I mean, Mason, I'll tell you that I just use another piece of mesh, and I just fill the soft tissue gap with an inlay bridged piece of mesh, essentially, to prevent motion of the second piece of my original sublay mesh, to close the gap under physiologic tension, to reload the muscles on tension. I mean, it serves the purposes of a free flap without the morbidity of a free flap.
So can I ask, when you say that it has function, so the muscle that you implant, does that, do you think it contracts properly? Is it properly innervated?
If you include a nerve in the flap and suture it to a nerve in the donor area, in the recipient area, then you have contraction of the muscle and you have sensibility even in the surface of the skin.
So for midline, is that what you do? You suture the nerve as well?
Yeah, so as you perfectly saw in the video that I showed, this was a myocutaneous free flap from the latissimus dorsi muscle that has a nerve, which is the thoracodorsal nerve, and you suture it to one of the thoracoabdominal nerves that are exposed usually after an oncologic resection. So this I am talking about oncologic resection. This was not a hernia, right? So there's a bunch of nerves in the margin of the oncologic resection. You choose one of them to suture the nerve there and expect that reinnervation is going to happen at the speed of 1 millimeter per day, which is what usually occurs when you put nerves together.
We're going to go to the next question over here on the right.
Just briefly, kind of based on that FDA approval of Botox, are the patients paying for all the units for their Botox most of the time, or how are you getting the availability?
So I think it's really institution dependent. Where I did residency, we actually had the plastic surgeons do it because, in the general surgery clinic, it would not be covered. Or, the plastic surgeons had to weigh private pay, blah, blah, blah. Where when I was at University of South Alabama, for whatever reason, we were able to get Botox in clinic covered by insurance, no issue. I guess, they had a way for the colorectal surgeons to do it for their anal sphincters, and it somehow managed to get shuttled into general surgery as well. So
I'll share what I do, and I explored a number of options. Asked radiology to help, IR to help, anesthesia to help, and now I just do it myself in the operating room. And I found that to be the most effective solution because the OR pharmacy seemed very willing to give me 300 units of Botox for my patients. And so I had a conversation with the head of pharmacy ahead of time, shared some data, and kind of got all the stakeholders on board. And it seems to have worked out pretty well. The hospital's getting paid, and everyone's doing okay with that.
John, how do you book the case? Because if you book it as Botox injection, the insurance says, wait a minute.
No, yeah, I mean, I've done about 100 cases. I've only had one denial prior to surgery, and one case, we didn't take her because it was denied by Horizon Blue Cross of New Jersey, not to specify, but I spoke with the medical director, and she was just, because my note actually said, interestingly enough, this is an off-label use of Botox. She said, we will not pre-certify this because it's an off-label use, which is very interesting. But nonetheless, I book it the exact codes that Bonnie referenced, plus ultrasound-guided injection. And I don't know what DRG the hospital bills. It's an outpatient procedure, typically MAC anesthesia. That's what I do.
I can add to that a little bit. I think when I was at Carolinas, we typically were able to get it approved. We sometimes had to do peer-to-peers, sometimes had to write letters. I don't know how often that's still happening there. But where I am now at the University of Florida, our RIR colleagues not only do the procedure, but they see the patient in the clinic preoperatively, and then they book the procedure, and they have zero pushback at all. I'm not sure if it's because it's their name and not mine, but all I know is it's extremely streamlined and has been really beneficial for our program.
We'll go over here, please.
So we were talking about the different options for the where we cannot close. Why don't we consider even organ resection?
As like reductive surgery, is that what you're asking?
So suppose you cannot close, though you will do a colectomies or something, just so that you can pack the abdomen and close the midline. This will be in absolutely very few cases, but it is one of the options which can be considered.
Yeah, I think it's an option. If you can't get the abdomen closed, and that's something that you've discussed with the patient and you feel like can be beneficial. I personally haven't done that. I don't know if anyone else has.
I'll tell you, if you're going to resect the colon to get the abdomen closed, I think that the consideration of the possible complications associated with that, even though it's small, are massive. And so, do you trade something that is an elective procedure, and if you say, well, Botox doesn't work, Botox pneumo doesn't work, weight loss doesn't work, I think you have to be very careful about resecting someone's colon and the endpoint of that, and the possible just the possible massive complications associated with it. We wouldn't get away with that in the United States. That to fix a hernia, resect a colon, and then if you had complications associated with that, not really. Excellent.
Thank you. Congratulations to everyone for this presentation. I'm Raul Rodriguez from El Salvador. Dr. Lee, do you have any problem with the FDA to use Botox here in the United States? And what are you doing to deal with these problems? Thank you.
So it's more of a barrier with insurance covering it or not because of the FDA situation. So if the insurance gives a lot of pushback, then the patient would have to be private pay. They just pay out of pocket for the Botox itself, which is pretty expensive.
Thank you.
Ali Amro, Cox House, Missouri. My question is for Dr. Sacco and perhaps Dr. Henneford, because he asked a similar question. For your case specifically, the first one, the combo case with OB, where they did a hysterectomy at nexal mass, and then you fixed the hernia and used the big stratus mesh. I know a couple of years ago there was this multi-center RCT by Rosen where they studied stratus versus a large synthetic like the Bartsoft, and they found same risk of complications but less recurrences, and it was much cheaper with the Bartsoft mesh. So I guess, has that data affected your practice, or do you still prefer to use the biologic meshes in those clean contaminated cases?
So if I remember correctly, I do think the mesh infection rate was still higher in that, not maybe a lot, but it's there. And for me, one mesh infection is too many. I think it's a conversation with the patient. The risk of recurrence is higher with biologic mesh. I think what is the risk of recurrence is way across the board, right? Dr. Henneford Group shows, I think, 9% when I was there, and I think it's maybe even down to 7 on the latest paper. So, you know, if you have a 10% recurrence rate with biologic mesh, great. I think if you have an 80% recurrence rate with biologic mesh, you probably shouldn't be offering that. So for me, it's a discussion with the patient. I would rather have a recurrence than a mesh infection, and I think typically we are able to provide a pretty good operation with the biologic mesh. So my choice still is biologic mesh. I think also there's a big conversation to be had with absorbable mesh. I'm personally still not using it for those cases, but I think people are. And I think it's still a little bit dealer's choice for what literature, you know, out there.
So I'll just start by saying that Mike Rosen was my fellow and is one of the best known hernia surgeons in the world, applies science the best way he possibly can. And he is somebody I truly respect. But if you look at that paper, and if you actually, one of the problems that we have, especially in hernia surgery, is our data is terrible. Let's just say it out of the gate, it's bad, and then maybe we'll go worse than that. But if you look at that particular paper, and it took 9 years to do that study, and Mike and I texted after that study on Sunday morning after it came out, and his words were truly amazing. He said, you know, randomized prospective trials are hard. They're not perfect. This is all, you know, we have to take the data, it is as it is. We just have to keep pressing. And that was in a text message to me. But I'll just say, if you look at that data, and there's over 250 patients in 9 years, the meshes were put in various places, and there's 64% of those patients had peristomal hernias. This is not a ventral hernia paper, it's a peristomal hernia paper, and 24% of those had recurrent peristomal hernias, and I can get Eric to weigh in on that. If you want to make yourself look bad, look at your peristomal hernia outcomes. This is a 2-year study, and then in a 2-year study, so if 2-year study, they had 46% of the patients, like 124 patients didn't show up for their follow-up. And then if you break down, like, how do you make this study no longer statistically significant? If you look at the fragility of that study, there are 2 websites where you can put in the number of patients on each arm and the outcomes in each arm, and how many patients would have to change to make it so it's no longer statistically significant. It's 7. So, you know, if you want to say this is what the data is and this is what our mesh choices is, I'm going to say that's not true. And then if you look at the, we can do this for, even if you look at mesh versus no mesh in the randomized prospective trials, of which 11 were positive, we can start breaking down that data, and we can go and go and go here. And what it ends up being is, young people in this audience, you guys can, like somebody told me yesterday, like, there's like so much that's been done, there's almost nothing else to be discovered. There is so much that can be done to make us better. So read the paper, break the paper down, and then you'll actually see that there's really, what the real data is, and the lack of validity of those cases.
Thank you.
I think the photographer got an awesome shot of Dr. Henneford in the zone. In the zone. Thank you for doing that. I'd like a copy. Are there any other questions from the audience?
One from the panel. Anybody else?
I was just going to say, as a counterpoint, I would have no problem using a permanent synthetic mesh in the situation outlined. Like, none at all. I couldn't tell you the last time I used a piece of biologic mesh. I couldn't.
And I think that just goes to show, the consideration of, like, we really don't know what the right answer is until we get long-term follow-up, like operations, in like patients.
All right, well, I'd like to thank our speakers. A round of applause for our speakers. This brings this session to a close. Thank you guys for coming and your participation. Have a great rest of the meeting.